All right. Hi, everyone. Thank you again for joining and the opportunity to speak on our project on this QI initiative on efficient utilization of stool, ova, and parasite testing in the inpatient setting. Um, Briefly, in terms of the outline for today's talk. Sorry, before that, I do not have any conflicts of interest to disclose for this session. In terms of the outline, we're going to start by understanding a little bit about the healthcare burden due to infectious diarrhea, followed by the guideline-directed workup of infectious diarrhea, and last but not the least, our QI initiative. So why is this important, or why do we care? The CDC, or Center for Disease Control, estimates nearly 48 million cases of acute gastroenteritis in the United States annually. And this leads to, in terms of healthcare burden and costs, about the estimated cost is approximately 150 million US dollars. And we also have studies that have shown that appropriate testing when necessary and diagnosis significantly decrease endoscopic procedures, abdominal imaging, antibiotic use, and in turn reduces hospital length of stay. Coming to the guidelines, for the purpose of this talk, we're going to focus on two guidelines, specifically the IDSA guidelines, which is from the Infectious Disease Society of America. And they recommend against ordering a comprehensive stool, ova, and parasite exam in patients with diarrhea lasting less than 7 days, in the absence of risk factors being immunodeficiency, travel or living in endemic areas. And if diarrhea persists greater than 7 days, they recommend considering a molecular or antigen-based test first, and if negative, proceed with a stool, ova, and parasite exam. Coming to the American College of Gastroenterology guidelines, also along similar lines, they also recommend diagnostic studies, stool studies, in cases of dysentery, moderate to severe disease, and symptoms also lasting for greater than 7 days. And traditional methods of diagnosis, such as bacterial culture, stool, ova, and parasite exam, often fail to reveal etiology in majority of the cases. And if available, the use of FDA-approved culture-independent methods of diagnosis are recommended, at least as an adjunct to traditional methods. And these are strong recommendations based on low or very, very low level of evidence. Coming to the comparison between the two tests, we have the molecular test, so the GI-PCR on the left-hand side, and stool, ova, and parasite exam on the right. This molecular test has the advantage of detecting a broad coverage of pathogens and identifying co-infections. Stool, ova, and parasite exam also has that advantage, covers a broad set of pathogens. In terms of sensitivity and specificity, it's as high as 94% and 98.6% respectively for the molecular tests. And for stool, ova, and parasite exam, the sensitivity and specificity is based on the observer, as these tests are performed by skilled laboratory technicians in the lab. In terms of the timing of results, the molecular tests do come back fairly quickly, within 1 to 5 hours, whereas a stool, ova, and parasite exam can take up to 48 to 90 hours. In terms of costs, molecular tests cost anywhere between $70 US to $200 US. Stool, ova, and parasite exam, on the other hand, costs about more or less the same, $90 US to up to $300 US. Molecular tests, as these are run in the lab, low cost of labor. On the other hand, stool, ova, and parasite exam is labor intensive. A single test can take up to 6 hours, and like I said, performed by skilled laboratory technicians. To touch up a little bit on the different pathogens identified or detected on these two tests, before we do that, it is important to understand that the prevalence of parasitic infections in patients with diarrhea in the United States is only about 5%, which is low to begin with. And the most commonly identified pathogens are 5, which include Campylobacter species, Salmonella species, norovirus, Toxoplasma, and Cryptosporidium. As you can see highlighted in pink, Campylobacter, Salmonella, and norovirus are all identified on the GI-PCR. That leaves us with two other parasites, Toxoplasma and Cryptosporidium. Toxoplasma is not identified on stool studies, so ideally you would do a serological test to detect it. And that leaves us with Cryptosporidium, which the point I'm trying to emphasize is that is only the reason why you would really get a stool O&P exam when the suspicion is high and the patients do have risk factors. Also to talk a little bit about how many stool samples are adequate or necessary to rule out a parasitic infection. This is a study where they compared 3 subsequent specimens, and it has a number of parasites detected. As you can see, this is a wide panel of parasites, and most parasites were detected on the first specimen. So this really emphasizes the fact that multiple exams are unnecessary, and a single exam is usually sufficient to rule out a diagnosis. Coming to our QI initiative, the aim of our initiative was to determine whether short educational sessions could be effective in changing provider behavior regarding ordering of stool studies. So we started by querying the EMR to find out how many tests were ordered in the pre-intervention period, followed by a retrospective chart review of 20% of the charts. We particularly identified duration of diarrhea, presence of risk factors such as immunocompromised status, history of living or recent travel to endemic areas where these infections are prevalent, and whether a GI PCR test was ordered before stool ova and parasite test was ordered. And in terms of interventions, we performed educational sessions for residency house staff, physician assistants, attending physicians in both internal medicine and emergency medicine departments. And we queried the EMR again to see if there was a difference in the number of tests ordered. So our pre-intervention period was between January 2020 to December 2020. As you can see, about 444 tests were ordered during this period. We reviewed 20% of the charts, which came up to 89 charts. And in terms of what we really found on our chart review, the duration of diarrhea, we found that only about 14% had diarrhea greater than 7 days. About 42% had one or more risk factors. Only about 4.5% had history of living in or travel to endemic areas. And only about very, very low percentage, that is 2.2%, had a GI PCR test ordered prior to ordering a stool OR parasite exam. And in our post-intervention period, this was 12 months into our intervention. This was between January 2021 to November 2022. We found that only 342 tests were ordered, and this is a 22.9 decrease in the number of tests ordered compared to the pre-intervention period. This is another diagrammatic representation of the number of tests ordered during the pre-intervention period compared to the post-intervention period. Finally, take-home points. I'd like to really emphasize on when to order a stool ova and parasite exam in the inpatient setting. Only if patients have diarrhea lasting greater than 7 days in the presence of risk factors. And I ideally order a GI PCR first. And if that is negative, proceed with an O&P exam. And within 3 days of hospitalization, this is based on the idea that if a patient develops diarrhea after 3 days of hospitalization, then you should really think of other infections, hospital-acquired infections like C. diff. Thank you for your patient listening, and I'm happy to answer any questions.
Thank you, Dr. Shenoy. Questions for Dr. Shenoy? And I think, Olga, will you let us know this? We will be able to unmute for audio, right?
Sorry, say that again, Rena.
How are participants still able to unmute themselves and ask?
Right now, no, we don't have that setting on, but can you see the Q&A?
Correct.
Yeah.
So folks, if you can put your questions into the Q&A tab at the bottom, and we'll be able to have Dr. Shenoy answer them. Thank you, Dr. Rip. All right, so one of the questions is, what was the proportion of risk factors in the post-intervention group?
Sure. Do I type in the
We
answer?
can speak, Shabari, yeah, because folks are live, so that's
Sure.
great, thank
So
you.
we didn't really do a chart review on the post-intervention group. As you can see, our data is very recent, as recent as November 2022. But I agree this is a great idea. Maybe we can look into it and perform a second set of chart review to see to identify appropriateness of these tests that we ordered.
Shabari, can you clarify what was the educational intervention that you conducted?
Sure. So we had presentations during academic half day, mostly focused on the risk factors and the guidelines, just the ones that I spoke about in my talk today, telling people what was appropriate, what wasn't. And just also, the other intervention was giving direct verbal feedback. As a second-year resident, or I was a second-year resident when I started, so I see a lot of patients with diarrhea on the floors in the ED. Just reminding people you work with was another intervention.
It's great, thank you. On the pre-intervention table for diarrhea greater than 7 days, the percentages don't equal 100%. Was there another group, or is this a typo?
I hope it's not a typo. I'm sorry for that. There was no other group, but I will check into that. I'm so sorry about that.
No, great, thank you.
But there were just the 89 charts that we reviewed, which came up to 20% of the charts from the ones that had the test ordered.
Great, and a linked question is, it seems you measured absolute number of tests before and after intervention. What about percentage of diarrheal cases instead of absolute numbers?
Yes, that would be interesting to see. We just assumed that these patients that had the tests ordered indeed came in with diarrhea, but that would be for that reason. I think a chart review would be helpful. Like I said, for one of the previous questions, to see as when you kind of review the risk factors, it would be interesting to see what their chief complaints were.
And then what was the proportion of risk factors in the post-intervention group?
So like I said, we didn't really do a chart review of the post-intervention group. It was a retrospective chart review of the pre-intervention group. That was 20% of the charts, and the data that I shared was from the patients from the pre-intervention period.
Great, thank you. Where were the majority of ONP tests, or where were the majority of ONP tests ordered? The ED, floors, so that you can target the most common prescribers if you identify the group?
So we saw a mix of both. Most tests were ordered within 3 days of hospitalization. So I'd like to say our patients fairly were in the ED for at least less than 24 hours or more. But I don't have the accurate numbers. But we saw a mix of both. But I agree it would be interesting to see to target those departments or those in those settings, and to tailor our educational interventions.
Great, well, thank you so much, Dr. Shenoy. All right, so I will introduce Brett Weingart. Brett Weingart is a third-year medical student at Icahn Mount Sinai. He's originally from Pittsburgh, Pennsylvania, and got his undergraduate degree from Emory University in chemistry and psychology. While he's still determining what field of medicine he would like to pursue, he has a special interest in medical education and bettering the learning environment for students in all disciplines. He spent a gap year prior to medical school as a high school chemistry teacher in Atlanta, Georgia, and it is incredibly important to him that he incorporates education and teaching into his day-to-day life as a physician, however that may look in the future. Welcome, Brett.
Thank you very much. And I will share the screen. Can we all see this? Yes, okay, great. So this study is titled The Impact of Virtual Reality Guided Mindfulness on Focus Prior to High Fidelity Simulation Debrief. I just want to start by saying thank you very much to Dr. Karani for the introduction and to IME for inviting me today. I have no disclosures, unfortunately. And so before we get started, I want to outline a few abbreviations that I'll be using. One is HFS, which stands for high fidelity simulation. VR stands for virtual reality. The STAI is the state trait anxiety inventory. And the VAS 0 to 100 is a visual analog scale ranging from 0 to 100. So it's a way for people to rate how they're feeling in a given moment. And the objectives for this brief talk today are to understand the benefits and limitations of virtual reality in facilitating a mindfulness exercise, and to recognize the role of mindfulness exercises in increasing focus and decreasing anxiety prior to high fidelity simulation debrief. So, an introduction on this study, some background information. High fidelity simulation is used to train residents, but in this case, specifically anesthesiology residents, to manage high stress situations. So it will emulate an operating room scenario, and they'll be asked to respond to different stressors and different clinical scenarios that arise. Physiologic stress is a common thing in HFS. It can enhance performance, studies have shown, but stress may hinder focus and knowledge retention during the debrief session after an HFS session. So after each of these simulations, the group will sit down and discuss what happened, what went well, and what didn't go well. And having these high stress levels can actually hinder the debrief session. Mindfulness exercises have been suggested to increase focus and decrease anxiety to improve learning during debrief. So this is things like mindful meditation that's guided. It can be kind of a reflection exercise, things like that, that encourage this mindfulness in meditation. And currently the existence of an ideal modality for mindfulness has not been established. So while there is some benefit to decreasing the stress level before debrief, the way in which stress becomes decreased has not been established. And pairing virtual reality with guided mindfulness exercises is become increasingly popular. VR is all the rage right now. You've probably seen it in your, maybe not clinically yet, but at least recreationally. And so we wanted to examine how this could be used in the educational setting. And so the objectives for this study, the primary objective is to examine changes in focus, anxiety, and EEG patterns in anesthesiology residents immediately after a guided mindfulness exercise that occurs after a high fidelity simulation, either with or without VR supplementation. And I'll detail exactly how we kind of ordered all of these interventions. And then secondarily, to determine the role of virtual reality paired mindfulness in aiding the student learning during that debrief session. So just the specific, kind of concrete outcomes we looked at. The primary outcome was focus. So we wanted to see if there was a difference in the amount that focus changed after this mindfulness exercise. And that's the difference between the VR and the non-VR groups while they were doing the mindfulness exercise. Secondary outcomes, one is to look at the anxiety levels after that mindfulness and seeing if there's a difference in how much anxiety changed between the VR and the non-VR groups. Another outcome is to look at composite EEG scores between the VR and the control groups during that mindfulness exercise. And then finally, we wanted to just see general changes in focus and anxiety after this meditation, regardless of VR supplementation. So these first two outcomes are looking at the differences in the VR and control groups, whereas this final outcome is just looking at overall participants, how did focus and anxiety change? And here's going into the methods. There's this graphic I made, and I'm gonna go through it step by step, but this is kind of the overview. So first we collected baseline demographics that was only done once. And just so you know, we used 26 anesthesiology PGY2 residents as our population. Then we performed the STAI, so the state trait anxiety inventory, and this was done weekly. This is to establish a baseline level of anxiety for each of the groups to make sure there were no differences in baseline anxiety levels. Then the residents would participate in a high fidelity simulation session. There were 5 different sessions that occurred twice a week. And the sessions, the first week was an introduction session. The second was emergence. So looking at kind of an emergency situation. The third case was hypoxia. The fourth was hypotension. And the fifth was a dysrhythmia. Then we did, immediately after the high fidelity simulation, we did this anxiety 0 to 100 pre-intervention. So we basically asked them to rate both their focus and anxiety levels on a scale from 0 to 100 before they did a mindfulness exercise immediately after the high fidelity simulation. And this is where the intervention comes into play. Half of the residents did a VR 5-minute mindfulness, guided mindfulness exercise while wearing the VR headset. The other half of the residents did the same exact mindfulness guided exercise with their eyes closed, so with no headset on. This is an image of what the VR environment looked like during the mindfulness session. It's a forest, and this is the company that makes it. But the only difference between this image and what we used was we were able to enable rain in this environment to make it, the reason we did that is because the audio from the guided meditation had some ambient rain sounds in the background, and we wanted the visuals to match the audio as closely as we could, so we enabled rain. Immediately after mindfulness, they were asked to do the exact same 0 to 100 scale of both their focus and anxiety levels. And then they would participate in the debrief session from the high fidelity simulation. And this happened twice a week for the groups of residents. The only thing that was once weekly was that baseline anxiety form that was completed. And the baseline demographics, like I said, was only conducted once at the very start of the study. So just to look at some results from all of the various forms of data we collected. Here's the participant data. Like I said, it was 26 PGY2 anesthesiology residents. This was a convenience sample based on who we had there. And there were 13 people in the control group, 13 people in the VR group, and you can see all of the sex, age, ethnicity data with p-values listed. So there were no statistically significant demographic differences in the two groups. You can also see we looked for prior experience with meditation to make sure that they were equally used to these kind of mindfulness exercises. And then the same thing with prior experience with virtual reality, because we wanted to ensure that it wasn't like one group was really good at VR and the other wasn't. Okay. And here's the baseline anxiety levels. So like I said, we did this once weekly for the two groups. And these are average STAI scores. So they're state trait anxiety inventory scores before this was done, like I said, before the simulation and before the mindfulness exercises. As you can see, there were no differences statistically between the two groups' baseline anxiety levels. So it wasn't like one group was more or less anxious than the other. And here is a table illustrating the primary and secondary outcomes. Like I said, the primary outcome was the change in focus between the two groups. And there's no statistically significant difference between the VR and control groups in the amount that their focus level changed after meditation. So there was no difference in adding VR in the impact on focus. Same thing with anxiety. There was no statistically significant difference of adding VR to their mindfulness exercise. And then third, there was no difference in their overall EEG score. And I haven't mentioned yet, but I should. We used something called the Muse. It's a consumer grade EEG headset. It's like a headband they wear, and it monitors kind of a consumer grade non-clinical EEG that's interpreted by their software. And they're given a score out of 900, with 900 being the maximum level of focus and 0 being a minimal level of focus. So a very high active mental state. And there was no statistically significant difference between the two groups in the amount they were able to focus or the amount they were able to, perform the mindfulness exercise created by this EEG app, which is called Muse. Here's a little more just detailed looking at all 10 of the different meditations they did. This is the average EEG score for each group. And like I said, the maximum was 900, and it's calculated, it's a weighted average based on the amount of time they spend in an active, neutral, or calm mental state. And it calibrates at the start of every meditation. It has you kind of sit still for about a minute, and it gets your baseline. And then any brain activity above that is considered active, and anything below that is considered calm. And then it gives you this weighted score. And for all 10 sessions, there were no differences in the two groups in the amount of calm, neutral, and active time spent on EEG. This is that final outcome that we were looking at. This is looking at all participants and how much their focus changed. So this is, each dot represents a participant. And so there are 26. I know they're all kind of crowded, but you can see, there's a pretty wide range, but there's no statistical change in the amount they've rated their focus. And this is a, subjective rating of their focus level after meditation. However, when we looked at the same thing for anxiety, you can see there was a statistically significant decrease in self-rated anxiety levels immediately after meditation. And this is a reduction by an average of approximately 19%. And I have the pre-meditation anxiety average. So the average of all of these pre-black dots was 45 out of 100. And then the average post score was 26. So a reduction of about 19%. So to kind of go into this a little bit, main takeaways, the addition of virtual reality had no statistically significant effect on the focus level, anxiety level, or composite EEG scores. So this suggests that it might not be super relevant to add on virtual reality headsets for this facilitating this mindfulness exercise after high fidelity simulation before debrief. However, across both groups, mindfulness exercises resulted in statistically significantly reduced anxiety levels, but not increased focus levels. And like I said, that was a reduction by about 19% with a p-value less than 0.0001. And the focus, just to give you some data on the focus scores, it was almost identical. It was back on this slide. The pre-meditation average of focus was 62 and post was an average of 64. So no statistically significant difference there. This suggests that mindfulness in any modality, whether that's eyes closed or with the supplementation of virtual reality, might be useful in just reducing anxiety before high fidelity simulation debrief. And why is this important? Well, having lower levels of anxiety could benefit learners in debrief. And specifically, there's literature citing it could improve recall ability if they're at a lower anxiety level. It can improve their attention during that debrief session. So it's easier for them to pay attention and discuss. And they could more objectively appreciate their performance in that simulation. So these are all benefits that would really just improve the quality of that debrief, especially after everybody's ramped up and stressed during the high fidelity simulation. And there are some limitations to the study, of course. One is that we used a consumer grade EEG headset versus a clinical grade EEG. This is analyzed by the app Muse, and it's not clinically validated, and it hasn't historically been used in research, but we used it out of convenience and the lack of having an EEG technician to administer and read a clinical grade EEG. Another limitation is the lack of synchronicity between the guided meditation audio that was stemming from the guidance and then the VR virtual environment. Like I said, we did our best to have them match up as well as we could by adding the rain and having the forest environment, but the Muse technology that does the guided meditation, when you're in an active mind state, the rainstorm sounds that it produces get louder. And then when you calm down, it becomes quieter. And we couldn't emulate that with the virtual reality environment, meaning the rain did not get heavier or lighter based on their mental state in the virtual reality environment. Another limitation are the EEG readings with and without visual input. So the control group had their eyes closed throughout the duration of the study. The VR group had their eyes open. And that's just a difference in the amount of brain activity that happens, whether you're receiving visual input or not. So it's possible that affected some of the EEG readings. However, we still saw no statistically significant difference between the two groups on their composite EEG scores that was read by the headband. Another limitation is our measurement for focus was the 0 to 100 VAS scale. This has been validated for rating anxiety, but it has not been validated for rating of focus. And we did see that statistically significant decrease in anxiety using this VAS 0 to 100 scale, but we didn't see the same for focus. So it's possible that the validity of that is questionable. Another limitation is anxiety and focus levels were used as a proxy for the quality of post high fidelity simulation debrief. And I think there's some need for further data on finding an optimal focus and anxiety level needed for learning. We did discuss there are effects, on things like attention and ability to objectively appreciate their performance by having lower anxiety and higher focus, but there isn't a whole lot of literature on that. And then finally, the sample size was relatively small, and it was just reflecting the diversity of the program, the PGY2 class. And like I said, this was a convenient sample based on who we had sitting in front of us. In terms of future directions, I think we could improve this study by using a clinical grade EEG that's interpreted by a professional rather than an app. However, in a realistic real life situation, I can't imagine many people will be strapping on a clinical grade EEG just to do a 5-minute meditation after simulation. So we did what we thought was realistic for actual intervention. And to investigate whether synchronizing, the audio and the visual between the audio from the mindfulness guidance and the visual from virtual reality, it's possible synchronizing those could lead to better outcomes with virtual reality augmentation. We could consider other metrics for focus and anxiety other than the 0 to 100 subjective scale. And we could examine whether higher focus and lower anxiety actually leads to better learning outcomes, and to determine whether better HFS learning and debrief leads to better patient outcomes. And that's a really difficult thing to measure because it's so longitudinal, but I think that's a really interesting place we could go with this. And so I'd like to just thank Dr. Katz and Dr. Burnett for their guidance on this project, and thank Dr. Karani and Mary Rojas for their advice and criticism throughout the study, and just thanking IME generally for this opportunity. And here's my contact info, and please would welcome any questions you have.
Thank you so much, Brett. That was great. I'm going to read out a couple of questions. This is wonderful work. Are you planning to do this with other groups such as faculty or clerkship students?
I think that would be a great place to take this. I think this is generally used to reduce stress after high fidelity simulation. So I think any learner that goes through a stressful sim session could benefit from this and could be studied in those contexts. Personally, medical students, from my experience, we don't do a lot of high stress simulators. We do a few simulations, but generally they're pretty calm and gentle and kind. And so meditating prior to debriefing those sessions might not be the most useful and relevant, but I definitely think there are other realms we could take this.
Great. An enlightening study. What is an EEG score and how does it reflect focus and anxiety levels?
Yeah, hopefully I went into that a little bit. Like I said, it's a weighted average of the amount of time spent in an active, so above baseline mental state on EEG, and a calm state, so below baseline, and it's out of 900. So that's how the score is calculated. And it doesn't directly reflect focus and anxiety levels. That's why we use the subjective 0 to 100 measure, and those were separate outcomes.
Great. What degree of anxiety reduction would you consider subjectively meaningful? Would 19% be perceptible to subjects?
That's a good question. And I think any reduction in anxiety would be perceptible because it's self-rated, meaning if I started before meditation and rated myself an 80 out of 100 on my anxiety level, I meditated and then even said, okay, I would say I'm a 75 now, so just a 5-point reduction. That's me subjectively saying, I feel less anxious than I did before, even if it's just a very mild reduction. So I think since we did use a subjective measure, even very small changes in focus and anxiety levels on the subjective scale are meaningful to the participant.
Do you think the focus levels would have been improved if the control group got no meditation or mindfulness exercise?
I do. I assume so. I can't know for sure because we didn't study that. But yeah, I wonder if we had a third arm of the study that had no meditation at all and just went straight from the high fidelity simulation straight into the debrief, I would assume they might report very different findings. And also there would be no way to measure change in focus or change in anxiety because there would be nothing, there's no intervention to break up the pre and the post rating. So I think that would have to be a slightly different study design. But yeah.
And then negative studies are often worthwhile. Were you disappointed by the results, or was a negative outcome one of your pre-study hypotheses?
Yeah, that's funny. I wasn't super disappointed. I actually think, although our primary and main secondary outcomes didn't have any statistically significant findings, we did kind of that post hoc analysis where we looked at all participants lumped together, just general changes in focus and anxiety, and that yielded a significant result. So I think that was comforting to see, okay, meditation isn't all for nothing. Even though we might not see a difference when we add VR versus eyes closed, the meditation still has a benefit in a place in the clinical setting. And I think that that's meaningful for education and for how we can train residents and administer these types of very high stress simulations.
Great. Brett, did you see any literature related to this kind of work in the industries that have used simulation so much, like the airline pilot industry and other sort of very high stakes, simulation training? Have any of them used this type of mindfulness as part of that training?
Yeah. Interesting question. I really limited the literature review to the medical realm. Searching on PubMed, I didn't really look at studies like, or I guess realms that weren't related to at least science and training and education of, medical professionals. But I do see it potentially being useful for any debrief of any high stress simulation. We did see simulation used in things like ALS and BLS certificate training, nursing, NPs, PAs, medical students, residents. So there's a lot of, medical context that I did look at, and, that factored into the literature review, but I didn't look outside of the science realm, but I do think that's an interesting place to take it as well.
Have you considered utilizing VR meditation prior to procedural training to reduce anxiety and optimize focus? Maybe you can assess the objective measure of procedural success during simulation, which then might actually directly impact patient outcomes.
Yeah, we didn't look at that. We were just looking at effect of meditation on debrief after a simulation rather than before a simulation, looking at how it affects the outcome of that simulation. Yeah, that's another really interesting thing. I think there are studies on that looking at, relaxation techniques prior to entering a stressful situation. But we were really looking to reducing that stress after this situation occurs.
Great. Thank you, Brett. Thank you so much.